would love for you to introduce yourself and tell us about your background and how you entered the cannabis space.
Yeah, so my name is Dr. Miyabe Shields. I use they, them pronouns. I entered the medical cannabis space honestly as a teenager because cannabis saved my life. So my exposure to cannabis from the very first time that I used it was as a medicine that changed my brain in such a way that allowed me to think that the rest of my life could be more positive. And the reasons for that have to do with like differences in the way that brains process the world. And even though I look very typical and capable, and honestly, as a scientist and as someone who's intellectually very successful, I often get sort of scapegoated with this like savant, like, oh, you're very capable. You have like a lot of ability. And that's very, very true. I do have a lot of ability, specifically in biochemistry. But that ability that I have in biochemistry comes with another side of the coin as well. And I have different types of invisible disability. I have chronic pain, I have GI issues, and I have neurodivergent challenges that, the diagnoses have ranged all over the place depending on what you're exhibiting. But like I have a trauma history in my childhood. It's early, and it's unclear whether or not I am autistic and have that as well. And I show and have been diagnosed with a lot of different categories. And cannabis has helped me because it helped me get off of a cocktail of psychopharmaceuticals that were just not working for me. And since then, I really dedicated my life to researching it. So for the past 15 years, I've been researching the system in the brain and body, the endocannabinoid system, the eicosanoid system, how those molecules that are inside us, that already play this role inside us, interact with the same receptors that are in cannabis. And then when I finished my PhD 8 years ago now, I went into the industry and started doing demographic, epidemiological research, doing curriculum development and public education. And then I also started doing research in heat transformation and chemical diversity of cannabis products, specifically like more analytical chemistry of like what is in here that isn't just THC, that isn't just terpenes, that isn't just even these new flavorants that we're talking about, even all of these other compounds. There's so much more to natural medicines, and especially when we're talking about preventative medicine versus band-aid solutions or cures. We want a cure. um, this is really where chemical diversity shines, and that 8 years ago was when I started more doing that research, because prior to that, the previous 7 years were academic
Ah,
research, and the academic research was all synthetics. So I've been really, really fortunate to have come of age as a scientist during a very changing and evolving time. I've been exposed to so much, and I was really, really lucky that when I started sharing my authentic version of my journey of cannabis, my formulations, and how it has helped me, that the feedback and the reception from the community was extreme. And I was not an advocate for cannabis before sharing about my journey with my mental health. And when I started talking about my own personal cannabis use, the reception from the community and what information it came back to me with has totally changed my research career. And I'm really, really excited for our partnership because I am passionate about this. This isn't just like a 15-year long research project to me. Like, I'm spending the rest of my life researching this medicine, how it helps people.
I
Like,
love that you talk about neurodiversity as well. I teach a cannabis health and science class at NYU in Syracuse, and when I talk about this with our students, about how does cannabis play a role in higher education in students that are undergraduates and graduates, postgraduates, how they can assimilate material, how do they deal with mental health issues? Because a lot of our patients are on multitude of prescription medication, maybe Ritalin, antidepressants, anti-anxiety medications. Can you speak about how that started for you? So you're on a cocktail of medications that may or may not have worked for you. Maybe they worked for you when you were younger and they helped you in that situation. But after a while of getting prescribed these medications, you look, oh, a decade, I've been on this 2 decades, but it doesn't serve me. How was that transition for you in thinking about integrating plant medicine?
I think this is such a personalized question. And a lot of people reach out to me about my opinions on the psychopharmaceuticals and also in mixing them because, you know, to be stated, you are a medical professional. I am not. I'm a research scientist. So like my doctorate is in philosophy. And in the philosophy of taking molecules every single day for health and wellness, in the philosophy of using molecules, drugs, and medicines as tools, as accommodations, as ways that we increase our quality of life. The philosophy there is no different between cannabis and the psychopharmaceuticals. The real difference is the way society views it, because the medicines, it's like itself, there are advantages to both. Like there are advantages to psychopharmaceuticals, and I don't want to demonize them or make anyone feel like I would demonize anyone for what works for their bodies, because it is different. And I know that from the feedback that I get from the community, that it's quite common for people to find a balance that includes cannabis, that also includes lower doses of their
Yes.
medicines. So it's such a difficult question, because for me, it was really clear from the start that I experienced medical trauma. First of all, my first psychiatrist didn't believe that I was gay, and also didn't believe that I had attention issues. And so those two things are undeniably true also. like yes, I'm very good academically. That doesn't mean that I don't have a very short attention span and like a difficulty with sitting in a space quietly in a sensory environment. And in addition to that, yeah, I'm definitely queer, and his opinion on that was very clear. And so this was, 2009, 2010. So it seems recent, but it really wasn't. And social change has come a long way since then. So I have a very unique story. And then I could say that I have a unique story, meaning that, my journey with psychopharmaceuticals started with medical trauma, but it's actually not that unique. And there is a known trajectory of how people who start entering the standard system of mental health end up being disenfranchised by it, and then end up losing their self advocacy, losing their self determination, losing their ability to really even dictate whether or not their mind is an accurate representation of what's happening. I was being told that these medicines would help me, while meanwhile I was degrading mentally and rapidly by taking these medicines. And that contrast to me, after a year and a half of trying a good number of things, and honestly probably faster and more intense of a ramp than what is advisable for my brain, but it was not working in such a way that was such a contrast to where I was being gaslit and told that, I'm right because I'm a medical doctor. And I'm like, well, I'm in my head right now and I'm very dissociated, and I was not like this, before that. And so I think that what's hard from that is that patients that are like us, it's very common for cannabis patients too. It's really, really more common. So when I say it's like, oh, this is a unique story, it's unfortunately not unique for the neurodivergent cannabis population. And what it came to was having to literally feel inside myself, I am gay, and also I have attention deficits, and that these medicines that I'm being told are helping me, like in the reality of when I'm looking at what my life is like, they're not helping me, because I'm not experiencing joy. I'm not experiencing love. I'm not feeling support. I was struggling in so many huge numbers of ways. And I had the luck of having a lot of experience with cannabis
Before, I see.
that happened,
Okay.
which I will say, and I have to caveat it, plenty of medical professionals who listen to this are going to say that dictated what happened to me,
Yes,
for sure.
agreed.
But
And
they
I,
were not in my brain.
but they were
So
not in your brain. And I do want to put a bookmark on that, because as a clinician, I have many colleagues that are for cannabis and against cannabis. And I was talking to a colleague who's a really well-known psychologist, and she said that cannabis medicine can actually, or cannabis, she didn't call it cannabis, but she said cannabis can actually numb you, and it actually doesn't help you deal with the day-to-day um, emotions of someone with ADHD or someone with anxiety or someone with depression, but that the medications don't numb you and the medications give you coping. And I pushed back on that, but I'd love to hear your thoughts on that.
no offense to her, but that's incredibly naive and ableist. Like,
Mm.
I'm not gonna sugarcoat my words anymore when I think something's discrimination, because it absolutely is. And the fact of the matter is, can it? Yes, it can. That's a truth. Can the psychopharmaceuticals? Yes, they can. So that's also a truth. And to position one as an higher up in that hierarchy over another is just ignorant at the molecular mechanism level. Unfortunately, many medical professionals are, because they have been brainwashed. And unless they want to take the work, like do the work to, first of all, decolonize their minds, because we can't actually have these conversations about cannabis without looking at the difference between how we view natural medicines versus the patentable, synthetic, extremely profitable psychopharmaceuticals. So those, like, these conversations are all in line with like why people have that common misconception. And I don't mean to be insulting by it, because actually that is the common prevailing opinion. It's just wrong, in my opinion, scientifically, because it is true that cannabis can help you dampen. That's certainly it. It's also true that some brains are too overstimulated to process unless there is some of that dampening and some of that background. And to speak to the point about people who are going to accuse me of saying that like my early cannabis use as a teenager is what caused me to develop more intense things as an adult, that's not true. I had self-harmful and self-injurious behaviors as a child, and cannabis actually stopped my cutting and my burning.
Mm.
So it completely stopped it the day that I started using it, like the very first day.
I
So,
appreciate that, and clinically speaking, I see that all the time. I would love for you to explain in layman's terms the molecular mechanism. Let's say if you compare psychopharmaceuticals to cannabis medicine, how are they the same and how are they different?
okay, so this is great. This is a great question. The way that they're the same is that the drug itself, the molecule. So I think I can do the example that makes a lot of sense to do is Prozac, because Prozac is one of the oldest SSRIs in the book. Fun fact for people, Prozac is only 3 years older than me. Prozac has only been on the market for 3 years longer than I've been alive. So it's at this point 38 years old. Prozac's a millennial, so say what everyone's saying what they are about millennials. Let me just say that many of people are like taking a millennial every day that we're still figuring out what the molecular
Gosh.
mechanism is. So Prozac is fluoxetine. That's what the molecule is called. And in cannabis, let's focus on THC, even though my main scientific goal of education is to have people not focus on THC. Right now we will.
Okay.
These are active ingredients, right? And in cannabis, it's so much more than THC, but THC is one of the main medical and medicinal molecules in cannabis, so we'll focus on that. And in Prozac, it's fluoxetine. So we have these molecules. We're taking them in. So for Prozac, you eat it like a pill. Cannabis, it could be a pill. It's an edible. It could be smoked. It could be inhaled. That's another advantage of natural products and medicines, is different methods of administration, what it's called in farm sci. But regardless, we're getting those molecules into the body. They get absorbed. So these are all common things. The molecule comes from outside the body. We take it, the body absorbs it, and then it interacts with what's called a target, like a drug target within the brain. And that's receptors are very common drug targets. Enzymes are common drug targets. And what these molecules actually do is they go and they will actually kind of integrate within these receptors, change the shape. And it's very cool. I'm super nerdy about it, but the biochemistry is fascinating for how there's this fit where the molecule itself makes the receptor change, and it turns it on. And it's three-dimensional, it's electrochemical, it's fat interactions, it's a physical movement that happens that then turns these receptors on or blocks these receptors, or has an interaction that's desirable. And then that change in the receptor goes on to have a huge domino effect. It's called cell signaling. And cell signaling, there's so many different types of cell signaling pathways, many, many different types. And I'm going to focus on two different receptors, two different types, and the differences, because that's the part of it that's the same. And then one more part of it that's the same is going to be after I talk about the activation, which is how our body processes it and then excretes it. So those two things are going to be the same. How the molecules come from the outside, they get into our body, they interact with something, and then how it gets out of the body is very, very similar. What's different is the chemical diversity, which is the number of molecules, because in pharmaceuticals, there's almost always only one, unless you're looking at a compound
Yeah.
development, like Midol or like Excedrin, right? NyQuil. If you're looking at one of those like formulations that are like mixed, but otherwise most pharmaceuticals are just a single molecule. They're they're synthesized and they're purified, and you're just getting that one molecule, and they're usually very strong, which means that when this one molecule, so for example, Prozac goes in, it binds really tightly to the serotonin transporter molecule, or I'm sorry, transporter, which is why it's called a reuptake inhibitor, because it comes in, it binds to that, and it inhibits the reuptake. That's what SSRI stands for, selective serotonin reuptake inhibitor. Now, I think it's comical that we named it that because it's not selective and it hits a whole lot of other stuff. And that is a fun example for Prozac that if people are interested in it, like, is something I cover in way more detail in my course. But these psychopharmaceuticals that we say are selective and that have one target realistically do hit a lot more in the body. And especially as we take them over time, like the effect that they have, some of these psychopharmaceuticals will have tardive dyskinesia, which is like involuntary permanent muscular spasms and rigidity. And, there's some really serious things that we're taking into the risks rewards and the harm of the benefit cost ratio of these. One of the issues here with the psychopharmaceuticals is the illusion that they are safer than their alternatives, when we don't actually have, in my opinion, a good amount of context to say that. What is safer about them is the ability for doctors to be educated on them, and for the ability for the general public to get prescribed doses that are within the range of safety. Now, that is safer, but that has nothing to do with the molecule. That has nothing to do with whether the molecule is safer. That has everything to do with whether our society accepts and structures the medicine in a way such that it is safer and more accessible to the general public. And now I'm going to come to cannabis and say the difference there. So these are different targets. When I talked about Prozac and fluoxetine being on the serotonin side of it, that's a whole system that our body has. It's associated with happiness just in general, but that also has been disproven. The serotonin theory of depression has been disproven. And so,
thank you for pointing that out.
yeah. And so, I love my field. As a pharmaceutical scientist, I am very interested in drugs in the brain. I've always loved it. But we are at the point where our technology has developed and our ability to understand has developed such that we know that we've been going about things the wrong way for, I don't know, like 100 years or so. Not the wrong way. We've made a lot of discoveries, but we've also, been doing research based on a lot of assumptions that are not necessarily proving out to be true. And if anything, are just proving to be a bigger, more complicated picture. These receptors are not operating on their own. And when I say serotonin system, and I'm going to shift now to the endocannabinoid system, I'm going to shift to talking about CB1, we're talking about them like they're two separate systems. That's just not the truth. The CB1 receptor will actually bind directly to the serotonin receptors. And actually Prozac changes the levels of endocannabinoids in our body. So these systems, like, we have this illusion that they're separated, they're not. And we have this illusion that we've studied them to the extent that we understand, like, fully, but we don't. And I didn't know that until I got to the edge of the research, right? You come to the edge of it and you're like, this is all we know? Oh, that's terrifying. And when it comes to the natural medicines, we definitely have unknown. For sure, there is unknown there. But it is my opinion that there's far less unknown in at least the medicinal preparations of cannabis that are traditional and are more closely related to the chemical profile and chemical diversity of what is our natural landrace, natural hash, like old school charas and dry sift, and like especially like in properly aged products, these products actually have more lived experience and more testing over thousands and thousands of years, that for me, I know what to expect if I smoke weed for the rest of my life. I am not worried by all of the like fear mongering stuff that comes out about it, because I am way more worried about the experimental stuff that I put in my body less than 4 years ago. And I think that perspective is one that people will label me as a radical person for having that, but I'm just really educated. And that's just from my perspective. Everyone it's free to have their own opinion about it. And the amount of lived experience that I have with medical cannabis and the amount of research experience that I have, like in the atomic scale interactions between these molecules and the targets that they interact with, the mechanism of them is, it's so beautiful. It's so beautiful. So the CB1 receptor, when THC will bind to it, so this is in the endocannabinoid system, that main function is it's inhibitory. And that's why people will say, Cannabis makes you slow. Cannabis makes you dumb. Cannabis reduces spontaneous signaling of your brain cells. Cannabis and the activation of the CB1 receptor is inhibitory. It means that it reduces, it reduces signaling. That is its main, most general functionality. Now, that's also not always true. And it depends on the circumstance of what brain cell you're in, what other receptors are there, etc. And people say that, if cannabis makes you slower, the reality is that some brains are too fast. And so it's not always a bad thing to slow down. And I would argue that going all the way back to the whole me pre 15 years old, that was not a good brain for me. And that was not going to be sustainable.
And we do have patients that say that. That say, I have a Ferrari brain, but I have bicycle pedals for brakes. And cannabis does help ground me so that I can be more productive. Otherwise, I'm trying to juggle 100 things at once, and it's overwhelming, and it creates anxiety and panic. So I love that you talk about it in the inhibitory sense.
It's not bad.
It's
not
not
a bad
bad.
thing. It's
It's not a
bad.
bad thing.
Yeah.
I would love for you to say, because I love how you compared the SSRIs with the cannabis. Can you say a little bit about SSRIs in general? Because, the research shows that a lot of the SSRIs are the same pharmacokinetic pathway. So there's really no differences between them. But when you look at plant medicine, you're talking about single molecule SSRIs, but then you look at plant medicine and the different strains and the different terpenes and flavonoids, there is a wider array of plant medicine and how that can affect the body. Say a little bit about that.
Totally. I think it's interesting. There are advantages. So there are advantages with using single molecules. And one of those advantages is reproducibility, which means that it's just it's the same thing that you're getting every single time. Kind of what you said with the molecular mechanisms of SSRIs being fairly similar. And the differences being slight changes in their structures, so they absorb differently, or so that they are absorbed slower, formulated so they're over longer periods of time, etc. But that overall mechanism will be the same. And every time that you take that pill, there are really, really rigid standards about how close it is going to be to the same every single time. And it's virtually going to be the same every single time. And that is different from cannabis and from natural medicines. And also the key difference that we have here is chemical diversity. Just the number of molecules. Cannabis has 300 to 400 molecules that are different and unique, let alone just total molecules that are in there. And when it comes to the type of extract that you're creating, that type of extract is going to be very different. So if you go through the process of doing isolation, distillation, and you end up with just these isolates, everyone has seen CBD isolate products, or products that are formulated with isolates, that is closer to a pharmaceutical. So also distillate, I'm personally not a fan of distillate, but something that is distilled means that, similar to how alcohol can get distilled and gets concentrated, cannabis distillate is usually almost all THC or all CBD, depending on which one they're trying to distill. And so there's all these different types, and distillate and isolate are the closest to this pharmaceutical realm, because it's very, very close to it. It's just one molecule. Sometimes people formulate with 1-to-1s using isolates, etc. And I think that they have their purpose for that matter. Just full disclosure, I bulk order CBD isolate because if I am getting really anxious or I'm triggered and I'm having a really hard time, I take pharmaceutical doses of CBD, which, by the way, are very high, 200 milligrams minimum at a time. And so that's why I buy it in bulk, because if I'm going to need to pharmaceutically dose, I need 200 milligrams 2 to 3 times a day. I need it for 2 weeks at least, or something like that. Then, that's going to become unsustainable financially, and it should be covered by health insurance. And that's another conversation. Yeah. But these are the advantages to isolated products, right? These are the advantages, because if I'm experiencing something extreme, me going to that pharmaceutical dose of CBD, first of all, I know it's not going to give me anxiety. And I know that it's gonna have this same effect every single time. So that's the advantages to the single molecules, and cannabis has them too, because we have the isolates. So that's their advantage. And the second advantage of the pharmaceuticals is that your doctor is prescribing them, and your doctor is evaluating you, and you have this third party, or you should have this third party check of whether or not something is working and effective for you. I find that to be an equal problem, but that's because medical professionals don't understand my lived experience, or this is a difficulty that has to do with health equity. some people are just not going to be able to access the medical system in the same way. So that advantage only exists for people who are privileged enough to access the system in a way that helps them. And
Exactly.
that's not
Exactly.
most cannabis patients.
It's not, and and that's what we pride ourselves at Leafwell. We have over 100 providers in 30 different specialties. Over 50% are BIPOC practitioners, and it's important to have culturally competent practitioners. So culturally competent practitioners that understand integrative medicine, like plant medicine, but that can also understand prescription medication. So to your point, I am a chronic pain survivor. I have an autoimmune disease, and I've lost count how many times I've seen a practitioner give me an eye roll, and that completely just changes the whole dynamic, and it just makes you compress into your condition, your disease, and your illness. And when you're young and you don't have an advocate, it can really change the trajectory of your life and how you see your health and how you advocate for yourself. So thank you for bringing up the topic of health equity, because that's something that we don't talk about enough.
And it's the eye roll thing that you're describing too, like, when you don't know more than them, and when you are just, feeling like you're a bad thing. Because
You're a bad thing.
a lot of times chronic patients are made to feel like we're the reason why the medicine isn't working. I also have chronic pain. I don't have a memory from when it didn't begin because I'm hypermobile. So I'm assuming it's just been, my entire childhood and life. And I mean, I'm a childhood trauma survivor. So that also contributes to chronic pain. I have not met someone that has my level of chronic pain and my level of stuff that doesn't also have depression, right? Like, is it's difficult. And then in addition to that, GI issues. I call it the triad of suffering, but like there's this triad of suffering of like mental health, GI issues, and chronic pain that really are working together. Are like it's just a synergy of issues that tend to come with inflammation, autoimmune disorders also, this pro-inflammatory thing. And cannabis, going back to the inhibitory nature of CB1, that's a powerful anti-inflammatory as well. The things that the endocannabinoid system controls, energy metabolism, overall brain signaling and hyperactivity, and inflammation in the immune system as kind of like these big ones. I mean, those are some three huge things for this medicine to help with, while also being the least toxic thing that we have been able to find, at least acutely. And the domino effects of cannabis, of the CB1 receptor being activated, those domino effects of how they can have an effect on so many different things. And like, I think that's why people think it's like, oh, it can't help with all these things. It's like, well, yeah, it can, because it's anti-inflammatory, and inflammation and stress, and not like a bruised lip inflammation, your lip is inflamed, or a swollen ankle inflammation, not that. A chemical inflammation, a stressful inflammation in the brain. We know for a fact that that's the number one indicator for what causes flaring disorders or chronic things that have flares, to get worse. It's undeniable that my chronic pain is far worse when I'm sad. It's just
Yes.
it's just known. It's a very, very known thing. And it's also why people who have a lot of tattoos, it's common for us to know that getting a tattoo when you're depressed feels good, as
Good.
opposed to if you're happy, it hurts. Like, it hurts like a lot. And I think that these contrasts and this subjectivity of how cannabis helps us, the reason why, or one of the main reasons why we're dealing with such a stigma and a bias, like coming out of this prohibition, which we're not out of it yet. We are literally still in this prohibition. One of the reasons why we're in this, when we're in this prohibition, there's still this crazy stigma and this crazy bias that we're trying to fight against so hard, comes from the fact that our population of chronic cannabis consumers, medical patients, and especially people who really are medical, and I'm saying that I think most people are medical, but the people who need it when it saves your life, we are a different breed, and we are a smaller population, but we actually are a large population within the cannabis community. According to our early longitudinal data set, daily consumers can make up to, so using we reanalyzed data that came from the federal government, and the federal government publishes their data publicly. This is all in a white paper. I can send you the link, but we're
Please.
looking at the percentage of people who disclose to the federal government that they use cannabis every day, which could be a lie. It's also true that people don't want to tell the federal government the right thing if it means you're going to be a felon. Like, I'm very fortunate to feel like I would burn myself alive if they came after me in front of the steps
Mm,
of DC. So
mm-hmm.
I guess come after me. But like, I think that when it comes to this data, we have to take that with a grain of salt. But according to the federal government data, only 5% of the general population consumes cannabis almost every day, like 6 out of 7 days a week. And about 50% of that population, so 2.5% or so, is neurodivergent, like meets the criteria for experiencing psychological stress such that it has some disabling feature to you. It has some challenge associated with it. And that's a pretty high. So 2.5% like it's a low. We are a minority. We're a minority that crosses socioeconomic classes. We're a minority that crosses racial classes. We're a minority that crosses geographic classes. I think
That's
we're a
right.
minority that some political parties probably should start adhering to, because 2.5% is not nothing.
Right.
But at the same time, when it comes to who those people are who make up, even saying that it's up to the 5%, but the 2.5% of people that are using cannabis daily, and it's helping with challenges with self-care, for example. It's
Yes.
helping with focus. It's helping with executive functioning. It's helping with ability. It is a medical accommodation that is helping to improve quality of life. For that 2.5% of the population, we are certainly multiply socially vulnerable in general. The general overarching view of that is that we have over three different separate, categorized like diagnoses, like on average. On average, the more diagnoses that you've received specific to mental health and neurodivergent, so talking like the most common ones were ADHD, general anxiety, PTSD, major depression, autism. Those were like the
Mm-hmm.
the major, most common ones. But then also in there is traumatic brain injury, is multiple sclerosis, epilepsy and seizures, migraines and cluster headaches, fibromyalgia and other chronic pain that is like neurological neuropathy. Right? Like types of neuropathy that are definitely related. I don't know that people would call it neurodivergent, but they become these things that at a certain point, when you look more into neurodivergence, it's a sensitivity of the brain that then comes out in all sorts of ways, like in your brain and body. And that for our population of people, that the stoner neurotype, as Dr. Riley Kirk and myself are starting to call it, like for the stoner neurotype, for those of us that are receiving these life-saving benefits from cannabis, so we're using cannabis every day, and we are like, for what we are and who we in general are people who have multiple social vulnerabilities, and cannabis use is one of them. By using cannabis as medicine, by having this relationship with a plant that saves our life. First of all, I've been a felon since I was 15. So I'm going on now 17 to 18 years of being a felon. And that absolutely changes everything about it. And I have not been convicted. And that is something that is actually a huge privilege, an absolutely great privilege that I have experienced from being a model minority, from the privilege of my family. I'm fifth gen. So on one side, and then the other side of my family comes from Hawaii. So like I am American, which is another cultural difference that I think contributes to this conversation of why I'm here with my PhD and not in jail, and a conversation of why I'm not dead on the streets or in an institution. And it's cannabis and it's privilege. And I feel like that's one of the things that I feel the most strongly about with using the privilege that I've had to get the information that I do and that I do know now. I can't not spend my life doing this, because this is not right. Like what's happening to our community is not right. And we are discriminated against for our cannabis use, period. I have had
Yes.
a diagnosis of cannabis use disorder when that same psychiatrist prescribed to me with multiple very liberal prescriptions of benzodiazepines that I used to chew with whiskey. So,
Interesting.
I
I'm,
think,
and I'm so glad you brought that up. I was talking to one of our patients who's a 45-year-old woman of color with fibromyalgia, with tinnitus, with ringing of the ears. And she said the same thing. She said, I look at the Leafwell provider, the psychologist that sees me in Leafwell, um, as a privilege because I can get a medical certification. I don't have to go to another therapist that will label me as a cannabis use disorder. So it is a privilege to even be able to get online, talk to a provider that's culturally competent, get a medical cannabis card so that she's protected.
100%. And it's a privilege for us to even be open and aware to this. And that's where culture kind of comes into this too, of like, now that we've opened up the cannabis culture to with adult use, to, has a different evolution. It has its own arms. It's creating its own things that I am not really super amped about all of it, to be honest. Some of it's great, product formulation development, all of that, like amazing. And the research and the focus on research and the focus on safety metrics that like are important and I think are happening. And like everyone there's I could go on about all the problems, but like there are really good things that happen with it as well, with accessibility. And when it ultimately comes down to like what you're saying about like, someone saying like this is a privilege, and like the privilege that I have of speaking from it too is that I'm an academic researcher that is part of the population that I studied in academia. And I experienced how much a lot of people's perspective here in the ivory tower really looks down upon people like me. And depending on how I choose to look and disclose who I am, that is how much discrimination I experience in this space.
Mm.
So if I come to these presentations or these conferences or whatever, and I've got my Dr. Shields thing on and I hide all my tattoos and I'm not talking about like any of my consumption, and I'm like, dry or vaping or taking pens so I don't smell like smoke or anything like that, I'm going to get a very different response than if I come in there the way that I look in my everyday. And then also the way that I look in my everyday does disclose in some ways what my history is, because I
Yes.
look as I am because I want to. This is who I am. I'm not ashamed of it. And I also don't think that we should be. But I do think that we are discriminated for it, and that it's an important thing to think about within the medical cannabis, like specifically having a medical card is legal safety. There's that. I don't know that at this exact moment too, there's people who are always like, there's this like this benefit. Like, I think one of the biggest benefits of the medical card has to do with legal safety. And also the other thing about it, I'm really excited to get certified also because I don't have mine right now. It lapsed, like I had it last year. And the thing that I really like about it is that, we need to understand and educate people more and have people be part of this medical framework and this medical, because if we are not, so right now, when people look at the market, they say most of the market is adult use. And so most of the research, product development, formulations, and most of the money and resources is going towards adult use because that's what's profitable. Now, the more of us that are medical, have our medical cards, are building this understanding, the more people that are medical, the more that we can actually say like, hey, look, we are a significant population that isn't being met here. The research actually isn't looking into like the research that is looking into these therapeutic benefits, are they doing it with our community in mind? Are they doing it conversing with us and including us as part of the population as a marginalized minority that is being discriminated against and framed by this research institution as the problem? No, we're not being included. And if anything, we're being looked at from the outside, like looked
I
down
love that you
upon.
bring, and I love that you bring that up. It's interesting. I don't know if you know this, but at Leafwell, we launched our employee benefit plan in New Jersey. So the first city that we launched is the city of Trenton. So if you think about that demographic of minorities, of people of color, the civil workers of Trenton decided that they wanted to include an integrative cannabis care plan with their employee benefits. So
That's sick.
just like you carve out vision and dental, they have
Nice.
carved out Leafwell as an integrative cannabis benefit plan. So the employees, they can see a provider, a culturally competent provider that understands cannabis care, but as well as understand their specialty, like your rheumatology, your endocrinologist, your OBGYN, so that they have combined care. And we're able to collaboratively work with their local doctor. So there's 360 care, right? So there's advocacy on the cannabis front, but also combining the best of both worlds, conventional medicine and complementary plant medicine. And this gets covered by the city of Trenton, and we've expanded to other municipalities in New Jersey, Board of Education in Newark, in West Orange, in Teaneck. And when we started rolling out this program, as you know, I've been in a cannabis space for decades. I didn't think the Board of Education would be the first civil company, right? The Board of Education coming in and offering integrative cannabis care. To me as a mom, I think like, I don't know about my fifth grade, math teacher teaching my kids. Like, how are the parents going to think about that? I, of course, understand it, but from an optics perspective, how are the parents going to think about a fifth grade teacher, taking cannabis medicine? And when you think about it from an HR perspective, and this is the feedback that we got, half of our employees are self-medicating with cannabis. So it's not really up to the employer to say I'm pro or against. We need to support our employees where they're at. And if it means helping them navigate and getting the right insomnia gummy versus the daytime focus gummy, we need to help our employees. So they looked at it from a risk mitigation perspective. And I applaud them because we are contracted with Meritain Aetna, we're contracted with Horizon Blue Cross. So this gets covered by their insurance. And that
That
to
is
me is amazing.
amazing.
Yes.
Yeah, that gives me chills. Also, we should talk. I have connections within. I would love my local city to do that and to be
Let's do that.
like,
Let's talk.
yeah, I have the right people. So like we should get them together because this is amazing. Like I think that like that type of accessibility, that bringing it in, that type of, and it's also a normalization, right? Because when it comes down to it, people could think that people are getting really high, but the reality is people who use cannabis every day, this is the normal. I'm not high right
The
now.
normal.
Like,
Exactly.
I mean, I get
Exactly.
high, but not in my day to day when I'm doing my things. Like I'm doing it like this is medicine. It's not like I don't increase my dose, like which that's I think one of the common things that is a complication of cannabis is like when and where do you increase your dose? How do you do it? The fact that we control it ourselves is something that people don't necessarily like because it's viewed as something that like could get out of hand, and that's possible. It requires a lot of education and self control also and self-reflection,
Yes.
and it's
Yes.
a
And not
lot of
everyone's
self-evaluation.
and not everyone is ready for that. And we take it a step further. We have in-network dispensaries that offer a 15% stackable discount for those employees. So of course, as you mentioned with your isolate, you bulk purchase it
Mm-hmm.
because it's so astronomically expensive. So we want to make sure that our patients are not only covered on the provider sense, but that they can actually walk into a regulated dispensary, get discounted products, and then talk to the liaison at the dispensary as well. So education is key for someone like you. You're a researcher, you're a patient, you understand the pharmacokinetics, the mechanism behind it. But if you are looking at that fifth grade math teacher that does not understand how to manage her MS, but paying so much out of pocket cost for her at MS medicine and needs help with offsetting some of those side effects, having a provider, having someone at the dispensary, having a discount, all of that makes a difference. And I think that's the beginning of democratizing cannabis medicine and normalizing it. And I thank you. I love that you joined us today, and I hope this can be one of many more conversations that we have in the future.
100%. I'm really happy to have been here, and I think that the we talked about so many things, but like the main takeaway that I think people don't understand when it comes to the research and the relative risks of medical cannabis for medical cannabis consumers is that for the general population, it's you can say it's cannabis or nothing, and you compare those two. If you're doing the research on the general population, which is what they do, they say, okay, cannabis consumers have higher cardiovascular risk than the general population, right? And
Hmm.
the answer to that is that in that general population, in that 98.5%, sorry, 97.5% of people who are not neurodivergent daily cannabis consumers, in that majority of 98.75%, yes, if they stop using cannabis, their heart cardiovascular systems would ideally statistically be better because they would not be using something else. But for the population of neurodivergent people who have chronic issues, and not just neurodivergence, just really anyone with chronic issues who is going to always need an accommodation of some sort, need some form of accommodation. It's not cannabis or nothing. It's cannabis and more harmful substances almost always. And so I think that this conversation about medical, this push for like creating a new system that medical can be more beneficial and more linked in, like in terms of like what you're saying about a 360 approach, making it part of employment that are just services that are offered these are things that I'm really excited to see, because part of what I would really hope and envision is like a future, is like as a dream, is this like resurgence of the medical quality, the medical priority, and medical patients as people who are prioritized. And in terms of like, from this is just a statement from disability rights advocacies that I think really represents cannabis. There's a phrase that's nothing about us without us. And the cannabis community, specifically the medical community, has been left out of a huge number of political, medical, and research decisions during this prohibition. We still are. And for the most part, most people that are doing the research and that are doing, and most medical professionals don't have a direct connection to the legacy. And we're trying to change that. So I'm really grateful to be on here and speaking with you. I've been so happy to have known you since we met with ACAM years ago, but also just I'm excited that this exists, because I think that we can change this. And I think that we're here. I mean, we're all here saying we're willing to create these resources and have these conversations. And it's very clear to all of us that are interacting with medical patients and that are medical patients ourselves that, this is a life-saving medicine.
Yeah.
So I'm
Thank you,
really excited.
Miyabe.
Yeah.
Thank you. Thank you.